To the top of the hour, so we'll get started with ISGyP's live journal club for April 2021. The theme for this month is USCAP 2021 follow-up. I'm your moderator, Natalie Benet. So first, I'll just start off with some housekeeping. The ISGyP live educational series has several exciting upcoming events. The next two are the next podcast will be dropping on April 28th at 12 noon Eastern time. And the topic is IHC biomarkers in uterine smooth muscle tumors. And that's courtesy of Dr. Kianush Kihanian. And then on May 6th at 12 noon Eastern US time, there's a webinar with Dr. Simona Stolniku on updates of pathology of endocervical adenocarcinoma, classification, pattern assessment, and prognostic relevance of certain specific subtypes. The learning objectives for the journal club are listed here. They're the same as always, with a few highlights this month to provide mentorship, which we'll get into at the end, but these are the same as they always have been. And then the sort of cheat sheet that I provide normally when we are evaluating published literature is listed here, just for those who like to follow along and maybe grab a screenshot. It'll be slightly modified this month because, as you'll see, we're talking about abstracts. But this month's theme is follow-up from the meeting from this year of USCAP, and we have three presenters who are presenting abstracts that they presented in poster format at the meeting. And they will talk to you about their titles. These are their names, and I also have this slide just to introduce you to the three speakers. So first is Dr. Ashley Monsrud. She's a PGY2 at Emory University in Atlanta, Georgia, and with us as well as her mentor, Dr. Uma Krishnamurthy. Second will be Dr. Batoul Aoun, and she's a PGY2 at the University of Michigan in Ann Arbor, and her mentor is Stephanie Scala. And third is Dr. Rachelle Mendoza. She is a PGY4 at SUNY Downstate Medical Center in Brooklyn, New York, and her mentor is Dr. Ravi Gupta. So we're excited to have everyone here today. And the schedule will be, after I finish talking, we'll hear from Dr. Monsrud, then Dr. Aoun, then Dr. Mendoza. And at the end, we will have some wrap up and questions and discussion with not only the trainees, but also their mentors to talk about what the process was like at presenting at the 2021 USCAP meeting. So without further ado, I need to briefly just mention to those who aren't familiar, if you'd like to put a question to one of the trainees or about one of the topics, please put it in the Q&A at the bottom black bar. You can upvote other people's questions with that thumbs up button to let me know that it should be prioritized. And if you want to leave comments, you can put them in the chat. So now I will stop sharing my screen and we will hear from our first presenter. Dr. Monsrud, you can go ahead and start sharing.
Sure. All right, can you guys see my screen?
Looks great, thanks, go ahead.
All right, awesome. Well, thank you so much, Dr. Bennett, for that nice introduction. It's a pleasure to be invited to present at ISGyP. So thank you for this opportunity. Today, I am going to be talking about PD-L1 expression in cervical invasive squamous cell carcinoma and it being associated with poor outcomes. Our analysis came from an urban public hospital at Grady Hospital in Atlanta. One second. Okay. So a little bit about background, as everybody's well versed in probably at this point, but upregulation of programmed death ligand 1, PD-L1. It's an immunoregulatory protein. It's associated with adverse outcomes in several malignancies. As we know, cervical cancer is one of the most common gynecological malignancies, and with women, Black women being disproportionately affected. Studies are emerging with data evaluating PD-L1 expression in cervical squamous cell carcinoma. However, most of these studies thus far lack data on overall survival and progression-free survival. As we know, these factors are pivotal in the efficacy and guidance for physicians when considering treatment options. With surgery and chemoradiation being the mainstay treatment options now, PD-L1 could absolutely be a potential great targetable therapy option for management of invasive squamous cervical cancer. So our scope, because so many studies are being done now on PD-L1 in various malignancies, we set out to correlate PD-L1 expression with clinico-pathological factors and clinical outcomes in cervical invasive squamous cell carcinoma within a predominantly Black and underserved patient population here at the Grady Health System in Atlanta. Of note, included in our scope, before publishing this data, we do plan on going back and investigating the impact of race on the two PD-L1 groups and correlating with clinical outcomes. So our design, after IRB approval, we use formalin-fixed paraffin-embedded sections of 73 cases of cervical squamous cell carcinoma from 2010 to 2018. These were immunostained for FDA-approved the PD-L1 DACO22C3 monoclonal antibody, a CPS score of 5 or with greater 5 or greater with cells of interest having at least partial or complete membrane staining was interpreted as PD-L1 positive. So our PD-L1 expression was correlated with age, stage, disease progression, disease-specific survival. All data was analyzed using the SPSS statistical software package. Our Kaplan-Meier curves for overall survival and progression-free survival were plotted and compared using the log rank test. We used Cox regression analysis was performed to identify significant prognostic factors. We used a two-tailed p-value of less than 0.05 for our statistical significance. So here's some figures. I wanted to show, what classically PD-L1 negative staining is. For figure A on the left, you can see this is a normal mucosa having 0 staining for PD-L1. And then on the right, figure B, that's going to be an invasive cervical squamous cell carcinoma, which is also PD-L1 negative. And here, this is a good example of a low CPS score. So this had a CPS score of 12. And this, I just wanted to point out that, these are really going to take time to have to sit and count each cell and actually do the math for these that are, at a close CPS score cutoff. But here you can still appreciate there's membranous staining around tumoral, around your tumoral cells, as well as your peritumoral lymphocytes. Now here's a great representative photo, picture perfect of a PD-L1 positive, no question here. So on low power, you can see your invasive squamous cell carcinoma staining strongly positive. And I just really like to appreciate that, in this bluish peritumoral area, you can see the blush of brown within that area, and you go on higher power, and this is, picture perfect staining of these peritumoral lymphocytes also staining strongly positive. So for our results for our study, so far, PD-L1 was positive in 30 of our 73 cases, so about 41% of our cases. Both PD-L1 positive and negative groups had a similar age distribution, and 10% of our patients were HIV positive. A greater proportion of PD-L1 positive cases, about 73.3%, presented in higher stages, stages 3 and 4, compared with PD-L1 negative cases at about 46.5%. Our PD-L1 positive patients also had a worse 5-year progression-free survival at 25% versus 50% in the PD-L1 negative group. All of our deaths were cancer-related. The mean disease-specific survival was lower in our PD-L1 positive patients at 24 months or 2 years, compared with our PD-L1 negative patients at 36 months or 3 years. Our PD-L1 positive patients also had a worse 5-year overall survival of 40% versus 60% for our PD-L1 negative patients. So here's a table of our findings. And here you can just see that all of our, the data that I just went over, you can see our statistical significance here versus our PD-L1 and PD-L1 positive groups. So here I show our Kaplan-Meier plots of our overall survival on the left and our progression-free survival on the right. And you can see clearly the PD-L1 positive group is these red lines here. So for our overall survival, it is significantly less versus our PD-L1 negative group. And for our progression-free survival, same thing. You see that our graph shows our PD-L1 positive, our red line, at a significantly lower progression-free survival, which I explained in our results. So in conclusion, the mean disease-specific survival, the 5-year progression-free survival, and 5-year overall survival are all significantly lower in our PD-L1 positive patients. Our PD-L1 positive patients presented at higher stage of disease, stages 3 and 4, and by Cox regression analysis, the only stage appears to be an independent prognostic indicator, which is consistent with our current understanding of staging. This study highlights the potential of PD-L1 targeted therapy having a positive impact on our patients' lives, both in increasing their time without disease progression and living longer lives. So our literature review is still ongoing, but most studies do support our findings that patients with PD-L1 expression have worse overall prognosis, and treatment would in fact be beneficial for this patient population. A meta-analysis reviewed 7 studies that showed PD-L1 overexpression is related to poor overall survival, but not progression-free survival in all patient groups in cervical cancer. Only they found that progression-free survival did only show significance in an Asian patient population with cervical cancer. This study also suggested that PD-L1 is a promising prognostic indicator for cervical cancer. So for unexpected findings, we did a similar study just before this one. We performed an anal squamous cell carcinoma with PD-L1, and we found it to be associated with poor mean disease-specific survival and overall survival, but not progression-free survival. Whereas in this study, all 3, MDSS, overall survival, and progression-free survival, were all significantly associated with PD-L1 positivity in cervical cancer. In addition, another unexpected difference in these 2 studies is for our anal cancer study, the PD-L1 positivity was an independent prognostic factor for cancer-specific survival and overall survival, independent of age, independent of stage, HIV, and viral load. Whereas in this cervical cancer study, PD-L1 was not an independent prognostic factor, only stage was the independent prognostic factor for cancer-specific survival and overall survival. So areas of improvement. For our CPS score, you may have seen we used was 5. Knowingly, the current FDA approval is for a CPS score of greater than 1. In our study, we found a greater statistical significance in our evaluation of PD-L1 positivity and its correlations with our clinicopathological and prognostic factors when using a CPS score of 5 instead of the current use of CPS of 1. So we tried them both, but 5 gave us greater significance. I think this brings up an excellent point because we've learned a lesson from our efforts to standardize tissue preparation, staining, and scoring of HER2, a prognostic and therapeutic marker in breast carcinoma. We should also strive to develop a strict standardization, accurate staining, and scoring of PD-L1 in cervical cancers and other cancers alike. This is likely to take a lot of time, and I think it's going to go through changes similar to that were made for HER2 markers, which you all may be very well aware of. So another area for improvement is the costly benefits of certain PD-L1 antibody manufacturers. So we also performed a recent study that was also presented at USCAP this year, where we recognized that laboratories may have to explore which PD-L1 assays show the most reliable staining. We compared expression patterns of the commercially available DACO 22C3, which we used in this study, and cell signaling PD-L1 antibody in both anal and cervical invasive squamous cell carcinomas. So we found that 30 of our 73, so 41% of the cervical carcinomas, since that's our focus today, they were PD-L1 positive by the DACO antibody. By cell signaling antibody, the PD-L1 was positive only in 35% of those that were staining DACO PD-L1 positive. Cases with the lower CPS score by the DACO antibody were seen to be negative by the cell signaling antibody. all 10 of the cervical invasive squamous cells carcinomas that showed no PD-L1 expression by the DACO antibody were also negative for the cell signaling antibody. So in conclusion, our cell signaling PD-L1 antibody, although equally specific, lacks sensitivity versus the currently FDA-approved DACO PD-L1 antibody. And this brings up a really important point that notably 85% of cervical cancer-related deaths occur in low and middle income countries where cervical cancer is more prevalent. This makes it absolutely necessary and crucial to develop less expensive antibodies, whereas DACO is the more expensive one and cell signaling is less expensive, but that essentially both have good quality and can be obtainable globally by the people most affected by this disease. So our future ideas, we plan on using, since we know the CPS score includes tumoral and peritumoral lymphocytes, we'd like to investigate further lymphocyte subsets. And here's my references. And we have nothing to disclose. And thank you guys so much for your time.
Yeah, thank you for that, Dr. Monsrud. That was really nice. Yeah, I think you hit upon a couple of points there at the end that really have always hit home with me about PD-L1. It's you watch these prognostic markers coming on board and you know that a system is going to be developed. And this has gone through several permutations where at the beginning there was all these different manufacturers had their own scoring criteria. And now I think it's kind of becoming more standardized, especially with the DACO antibody, like you said. But as you note, cervical cancer burden worldwide is definitely not shared equally. So there are definitely countries where this could be more beneficial, especially since this is usually used in advanced stage disease, which tends to be more common in the same countries that have the higher burden. So those are really excellent points. And there was one question, and Dr. Krishnamurthy, you're welcome to unmute and turn on your camera if you'd like to participate in this part. The question from the audience was, is there a correlation between HIV status and PD-L1 positivity?
So in the cervical cancer, only 10% of our patients were HIV positive and the distribution was similar. We did not see a significance in the distribution and it was too low of numbers, but in invasive anal squamous cell carcinoma, 75% of our patients were HIV positive. We looked at the distribution and the HIV viral loads, and between the two groups, there was no significant difference either in the percentage of patients who were positive or in the viral loads.
That's good to know.
Thank you.
Yeah, that's a good question as well, because I assume that in some parts of the world where cervical cancer is more common, HIV is also endemic in a way that it isn't in some developed countries. And the other question I have, both of you, either one of you, Dr. Monsrud, you can answer. So what is the clinical demand like for PD-L1 in your settings? Are they asking for this testing on patients who with the upfront diagnosis, or is this something that's happening, down the line when, initial therapeutic options have been exhausted? What's your experience like there?
Yeah, you can go ahead, Dr. K.
Okay. It's only when advanced cases. We are not getting asked upfront. Upfront, it's only in, non-small cell carcinomas of the lung or, but not in the cervical field. We find those only by clinician request.
Okay, that's what I assumed, but I just wondered if maybe, it's kind of like you said with the breast prognostic markers, it's like you do those up front. So I wonder if we'll ever get to the point where we just do, especially with the prognostic implications, maybe, who knows? We'll have to wait and see, right? Yeah. Okay, so I think Dr. Monsrud, you can stop sharing, and Dr. Aoun, we can go ahead to your presentation. Looks good. You're muted if you don't.
There we go.
Perfect.
All right. Good afternoon, everyone. My name is Batoul. I'm a second-year pathology resident at the University of Michigan. Thank you so much for having me today. My presentation is about the utility of P63 staining and morphologic features in distinguishing between cervical microglandular hyperplasia and endometrial carcinoma with mucinous features. I'm going to start off this presentation with a case. So this is a 67-year-old female with abnormal uterine bleeding, and she underwent an endometrial biopsy. These are two representative H&E images of her biopsy. So in image A, we have endometrium here, and I want to focus on these kind of small to medium-sized back-to-back glands with minimal intervening stroma. Inside of the lumens of these glands are this kind of blue mucinous secretion with a few neutrophils. The stroma has a varying degree of inflammation. And one thing I also want you to focus on is the cells that are lining these glands are not really cytologically, or they don't really have that much of a pronounced cytologic atypia. Some of them have prominent nucleoli, but there's not really a lot of pleomorphism, and there's not a lot of mitotic activity. Now compare that to the section in part B here. There's a little more pronounced cytologic atypia. There's prominent nucleoli. There might be one mitotic figure. And again, look at these small kind of microglandular foci inside of this endometrium. So immunohistochemical stains were performed, and P63 was one of them, which came back negative. And the case was signed out as atypical glandular proliferation, and the differential diagnosis included complex atypical hyperplasia, endometrial carcinoma with microglandular pattern, and benign endocervical microglandular hyperplasia. Now, the patient elected to get a total hysterectomy after, and this is what the total hysterectomy showed. Obviously, we see endometrial cancer, carcinoma, and this is what we were seeing on the biopsy sampling, those kind of small to medium-sized, tightly packed glands. There's abundant mucin and abundant chronic and acute inflammation. And really in part B here, you can see very clearly the cells that are lining these glands have little to, that look very bland cytologically. So it's very easy for something like this to mimic and get missed as a microglandular, as an atypical microglandular proliferation. So the distinction between EMCA and MGH can be somewhat of a diagnostic challenge, especially when you're dealing with cases that have limited endocervical and endometrial sampling. Microglandular hyperplasia is a benign lesion of the cervix. It's usually characterized by small, tightly packed glands that are lined by bland cuboidal or columnar epithelium, and they're accompanied by a variable degree of stromal inflammation, luminal secretions, squamous metaplasia, and reserve cell hyperplasia. Now, although we typically associate endometrial carcinoma with like nuclear atypia and increased mitotic activity, it can have bland cytology, as we just saw, and low mitotic rate, so it can get misdiagnosed as microglandular hyperplasia. And the problem is the typical immunostains that we use to distinguish between endocervical and endometrial carcinoma are not really useful when our differential diagnosis is MGH. So the goal of our study was to examine the morphologic features that are present in these two entities and to investigate the utility of the P63 immunostain to help us arrive at a diagnosis. So why P63? Well, looking at a normal endocervix, we have two distinct layers of cells. We have the columnar cells, and underneath that, we have a layer of cervical reserve cells. Now, reserve cells are a small population of cells in the cervix. They're undifferentiated. They play a role in metaplastic processes like squamous metaplasia, and you can see here, this is a schematic diagram of how the relationship looks like. So they're typically subcolumnar, and they become very prominent in squamous metaplasia. So over here, we have a layer of our columnar cells, and then underneath are the reserve cells. They're kind of hyperplastic here. They're forming a focus of immature squamous metaplasia. Now, P63 immunostain is going to have a very classic characteristic pattern. It's going to have that nice linear subcolumnar reserve cell staining, which is very suggestive and very characteristic of microglandular hyperplasia. So we gathered 62 cases from our institution's pathology archive. We're a tertiary care center with an associated cancer center, so we do see a lot. We're a very busy GYN service. We gathered cases from 2015 to 2021. 24 of these cases were of EMCA with mucinous and or microglandular features. 26 were cervical MGH. 12 cases were signed out as atypical microglandular proliferation. Now, the age range of patients was a good age range. It was about 25 to 93 years old. 55% of the cases were postmenopausal females, 38% were premenopausal, and 7% were perimenopausal. It's also worth mentioning that from the 62 cases we have, 8 were seen from our consult service, which is pretty indicative that this is a problem that just spans multiple institutions, and it's really a diagnostic challenge. So we typically see those on our consult service. So all cases were morphologically assessed for glandular architecture, the presence of mucinous and or eosinophilic secretions, the degree of inflammation, the presence of squamous metaplasia, is there cytologic atypia, and is there increased or no mitotic activity. All cases were stained for P63 and P10, and they were assessed for the presence of P63 and the pattern of staining and the presence of P10 staining. Now, P10 in the GYN tract is typically retained in microglandular hyperplasia and in benign endometrium, and it's frequently lost in endometrioid carcinomas. The goal of P10 in our study is to basically serve as a confirmatory stain that yes, what we're dealing with is cervix and what we're dealing with is benign endometrium versus endometrium with a certain malignancy. So this is one of the images from our MGH cases. We can see here the morphologic features, kind of small to medium-sized glands. You can pretty much make out here kind of a nice layer of columnar cells with a layer of reserve cells that is hyperplastic in this case. There are foci of immature squamous metaplasia. There's some subnucleolar vacuolization. There's some mucin formation inside of the lumens. There's kind of mild degree of stromal inflammation. And again, P63 highlights those reserve cells really nicely, and P10 is preserved and retained in microglandular hyperplasia. Contrast to that, in endometrial carcinoma, we have here foci of, again, usually small to medium-sized glands. They're tightly packed. This is a very kind of microglandular architecture, which can sometimes fool us. But, and then I also want you to pay attention to the bland cytology. Again, it seems to be a recurring theme, especially in FIGO grade 1 cancers. So this was signed out as endometrioid carcinoma with microglandular features, FIGO grade 1. And then P63 in this case really helped us because it was negative, and P10 was lost, and further confirming our diagnoses. This is a case from a 45-year-old female with abnormal uterine bleeding. This is an endocervical curettage, and it was a limited sample. We had this focus of atypical glandular proliferation. There's some cells with mucin. There's some moderate degree of inflammation, and some of the cells here, if you look really closely on high power, have some prominent nucleoli, but otherwise they are cytologically bland. Another focus showed an area of squamous metaplasia. Now, looking at this, especially in a limited sample like this, you can't help but worry whether this is just a benign lesion versus an undersampled low-grade endometrioid. So this case was signed out as an atypical glandular proliferation. P63 in this case was focal. It was showing subcolumnar reserve cell staining and squamous metaplasia areas, but and then P10 was retained, but additional sampling was needed, obviously. So with that, follow-up endometrial and endocervical sampling just showed that the atypical glandular proliferation that we were seeing was actually MGH, and the linear reserve cell staining was pretty much there. Here, we're not seeing it linear-wise because the reserve cells have had a layer of hyperplasia and they're forming this immature squamous metaplasia. But knowing that there's preserved P63 staining and preserved P10, we were comfortable signing this out as microglandular hyperplasia of the cervix. Contrast to that, this is a endometrial biopsy from a 69-year-old female with abnormal uterine bleeding, and this is a case that we actually got, and on the whole slide, this was the only focus of diagnostic tissue that we had, this small little focus. So we can see some microglandular architecture, some degree of stromal inflammation. There is a mitotic figure here. So our differential was undersampled low-grade EMCA with mucinous differentiation versus MGH. There was loss of P63, and then there was also loss of P10. The patient did elect to get a total hysterectomy after, which clearly shows endometrial endometrioid carcinoma with mucinous features, FIGO grade 1. Again, note here kind of the bland cytology. There was overall absence of P63 expression and absence of P10, confirming our final diagnosis. So based on the analysis of the 62 cases that we had, microglandular, all the microglandular hyperplasia cases that we had were characterized by small to medium-sized tightly packed glands. There was squamous metaplasia, which is a feature that we typically didn't see in the low-grade endometrioid carcinomas. There was a low degree of cytologic atypia, but most of the cases showed no degree of atypia. P63 positive subcolumnar reserve cell staining, which did not fail us on all 26 cases that we had. That was a pretty consistent finding, and the P10 expression was retained. Both diagnostic entities had stromal inflammation and luminal secretions. And then the low-grade endometrial carcinomas had those more large complex glands, but sometimes could be microglandular. They had a low to high degree of cytologic atypia. There was some increased mitotic activity. There was non-specific P63 expression, and P10 expression was lost in the majority of our cases. So microglandular proliferations that had cytologic atypia, mitotic activity, and more complex glandular architecture were seen mostly in low-grade EMCA compared to smaller glands with bland nuclei and squamous metaplasia were more often seen in MGH. It is important to note that there is frequent overlap between these two. We saw cytologic atypia in MGH, and we saw bland cytology in EMCA. We saw no mitotic activity in some EMCA cases. So it's definitely worth putting a P63 stain on these cases. And one thing that I was reading in the literature that can help you but should not sway you in making a diagnosis is the history. So MGH is typically seen in reproductive age women or older women that are taking exogenous hormones. In a postmenopausal woman that doesn't have a history of progestin treatment, seeing something like a microglandular proliferation should prompt you to explore it further, because MGH, like endometrioid carcinoma, could be the diagnosis, and we're just missing it because, again, there might be low sampling or the tumor does not look cytologically atypical. So in conclusion, there's frequent morphologic overlap between MGH and EMCA. In addition, features that mimic endocervical MGH can be seen on the surface or at the periphery of some endometrioid carcinomas, which most biopsies and curatages are going to sample. The pattern and extent of P63 staining can help us in the accurate classification of these entities, because P63 positive subcolumnar reserve cell staining was consistently seen only in our MGH cases. These are my references, and thank you very much for listening. Special thanks to Dr. Scala for being my mentor on this project and my senior author, and for all her help putting this together.
Yeah, thank you. And Dr. Scala, you're welcome to unmute yourself and turn on your camera if you'd like to take part in this question part. I wanted to say, when I saw the title of this, I was like, clapping, and I couldn't wait to listen to your poster, because I find these cases to be very difficult, especially like you said, on small samples. And you wonder if you're sort of overreacting. And so any techniques that are helpful in this situation, and I think the design of the study is so practical. And it's also with a relatively widely available test, because most surgical pathologists use P63 routinely as a myoepithelial marker. So it's around, it's not something you have to bring on board and validate. P10 maybe not quite as widely available, but certainly P63, and then the enormous impact it can have for patients. So we do have a couple questions from the audience. Someone asked, what about Ki-67 proliferation index? they commented it should be lower, almost negative in MGH, but higher in endometrial cancer. I have a thought on this, but Dr. Aoun and Dr. Scala, would you like to take a shot first?
So I'll defer to you if you want me to, otherwise I can answer.
No, it's your project.
You can answer.
All right.
Dr. Scala.
So to me, there's not any cutoff that we know to use for the proliferation index to distinguish these. You can rarely have like a mitotic figure or so in microglandular hyperplasia, and not all endometrioid carcinomas have high proliferative activity. So sure, if it was extreme, like no Q67 or high Q67, that could help. But to me, for practical purposes, I think most cases would probably be in a gray area.
Yeah. Yeah, and I feel similarly to this as I feel about sort of trophoblastic proliferation sometimes, where you're trying to tell, hang on, is that a lymphocyte?
Yes.
Is it because
yes.
these are so inflamed, especially MGH, you know, you can get, I know, I mean, so maybe some people are better at mentally subtracting, maybe if you had some kind of co-stain, but I don't even know what you would co-stain.
Yeah, we do for trophoblastic things use a AE1, AE3 Q67 dual stain, but I feel like, at least in this context, I don't know that the utility of the proliferation index is high enough to justify charging for a dual stain.
Yeah, that's true. It's just like in any of these contexts, kind of using that maybe as like an extra bonus, like you said. And then someone else asked, I'm going to try to interpret this question. They said, did you find any additional benefit for P63 beyond P10? So I think they mean, and someone else also asked, are these the two stains you're doing in these cases? Are there any other stains that you use? Maybe we just talked about KI, but something else?
We initially just did like P63. Then I had a conversation with Dr. Scala about, and she introduced the idea of P10 as almost like a confirmatory or extra kind of marker to confirm what P63 is telling us, and seeing how P10 was very consistent in our cases of being retained in MGH and being lost in our carcinoma cases just really helped our results. But the plan was initially, when we were starting this project, was just to do P63, and then we got P10 on board, and it really helped kind of shape our results.
Yeah, the thing I'd add to that is we actually didn't have the P10 immunostain in our lab until very recently. We're still kind of working on how we feel about it in general. It does seem like in these particular cases, it has been very helpful to support what was happening with the P63 and morphology. But it does seem like in other contexts, it can be a little bit hard to determine what is really lost, because there's variable intensity staining. If you have weak staining while other stuff is strong, is that enough that you would call it lost? I don't really know.
I think that's one of those things that some people are so accustomed to using, it's just like second nature to them. But you know, there are some of us who didn't sort of come up with it, so it's a little bit more difficult to
so
learn
I think as P63 is more widely available, that's kind of the one that
and certainly your results validate that there's a clear pattern between the two with your MGH and sort of low-grade endometrioid cases. So that's very interesting. Okay, in the interest of time, I think we will move on to our third presenter. If you want to stop sharing, Dr. Aoun and Dr. Mendoza, you can start sharing your screen.
Okay, hi. Good afternoon, everyone. Thank you for having me this afternoon in your journal club. Wait, I think I need to start the slideshow. Okay, there you go.
Perfect. Great. Thanks.
Thank you. So I'm here to present our USCAP abstract that we presented in the last virtual conference, and it's entitled Overexpression of ISGyP in Ovarian Tumors is associated with advanced stage tumor recurrence. And this is done with equal contribution with my good colleague, Dr. Amir Digani, who's also going to Women's Health, and under the supervision of Dr. Gupta and Dr. CDK helped us write the abstract. So we have nothing to disclose. So this study has two essential components that I would like to give a brief background on, and that is the ovarian tumors. Essentially, with this study, we just meant to include only epithelial ovarian carcinoma. And we're all familiar with this. 90% of ovarian cancers are actually of epithelial origin, and epithelial ovarian carcinoma are histologically subtyped into different histomorphologies, and each of these histomorphology have their own unique molecular aberrations. For this study, we only included low-grade serous carcinoma and mucinous carcinoma, and they're benign and uh, borderline equivalent tumors. Now, I would like to give a brief background on what is EZH2. So EZH2 is short for enhancer of ZES homolog 2, and it is essentially an enzyme. It is a methyltransferase, and it is the catalytic subunit of the polycomb repressive complex 2, or PRC2 for short. And this complex, the main function of this is to methylate histone 3 at the position of lysine 27, lysine 26 sometimes, and also lysine 3 position. And this methylation, as we're all familiar with, leads to gene silencing. And in the context of cancer or oncogenesis, what they're silencing and repressing the transcription of is the transcription of your tumor suppressor genes. Now, EZH2 in ovarian carcinoma was found to be overexpressed, and the overexpression is linked with increased cancer cell proliferation, invasion, chemotherapy, and radiation resistance. This is not unique with ovarian carcinoma. It can also be seen in other carcinomas such as bladder cancer, prostate, breast, and even some types of lymphoma. In our study, we wanted to see whether EZH2 was indeed increased in a variety of epithelial ovarian tumors in our patient population. And we want to analyze whether the EZH2 overexpression can be useful in differentiating between invasive and benign and borderline ovarian tumors. And since we also collected several data along with the specimen of our patient, we also wanted to see whether EZH2 expression is associated with other clinical characteristics of our patients. We did a preliminary case selection from 2005 to 2014, and we found 68 specimens with benign borderline malignant serous and mucinous ovarian tumors. And we followed our patient retrospectively for tumor recurrence and survival for 5 years. We retrieved the paraffin-embedded formalin-fixed specimen, and we subjected a 5 mm tissue section for immunohistochemical staining using a rabbit monoclonal antibody to the N-terminal of EZH2. We used the clone EPR9307, which is produced by Abchem. We subjected the immunohistochemical staining using the Ventana benchmark XT protocol at a dilution of 1:50. After immunostaining, we graded the EZH2 nuclear expression and at least 100 viable tumor cells with a score of 0 essentially in tumors without any staining or less than 1% staining, score of 1 for 1 to 30% staining, score of 2 for more than 30 to 60% staining, and a score of 3 for tumors with more than 60% staining. We then evaluated the relationship of any clinical and histopathologic data and immunohistochemistry data of EZH2 using chi-square Fisher's exact test. And then we wanted to also see the relationship between multiple variables using logistic regression. And the survival data was analyzed using Cox proportional hazard model and Lagrange test using Kaplan-Meier curves. So for the results, this is the summary of the table of the clinical characteristics of our patients and the specimens as well. The mean age of our patient is 56 years old, ranging from 47 to 65 years. It is notable to see that more than 80% of our patients are non-Hispanic Black. This is based on a self-reported race on our electronic medical record. The other includes white, Asians, Hispanics, and a few who wished not to disclose their race. The majority of our patients presented with abdominal pain and distension, and the majority of our specimen were actually from benign ovarian tumors and serous type tumors. Um, Among the borderline invasive, there's like a 50% distribution between the early stage cancers. We combine stages 1 and 2 for early and stages 3 and 4 for late stages. Majority of our patients actually did not have any recurrence and were alive at the end of the 5-year survival, 5-year follow-up period. This shows the variation in the EZH2 expression in serous tumors. So there is a clear increased expression in tumors, which is in your right-hand panel, which is in an invasive low-grade serous carcinoma compared to your borderline and compared to your benign. The benign almost didn't have expression of EZH2 in the tumor cells, in the tumor epithelial cells. In mucinous tumors, it is much more difficult to differentiate them. We do see some more staining in the benign mucinous tumors, but there is still clearly evident that there is a higher degree of staining in the invasive portion of your mucinous invasive carcinoma. So we did find that there is significantly higher EZH2 nuclear expression in invasive ovarian tumors. There is 84.2% of the invasive tumors that increase EZH2 expression compared to 14.3% of the borderline and none of the benign. And among the cases with that are invasive, the increased EZH2 expression is associated with higher pathologic tumor staging, with increased FIGO stage of diagnosis and increased risk for recurrence. And also, EZH2 expression is predictive of shorter disease-free survival. This is our Kaplan-Meier curve showing that invasive tumors with a score of 3 in immunostaining has significantly shorter disease-free survival. So our results are actually in agreement with prior findings that EZH2 expression was increased in invasive tumors and that it is associated with poor prognosis. We also can confidently say that EZH2 expression can be utilized in differentiating borderline invasive serous and mucinous tumors in cases when you have a very difficult tissue and a very limited type of tissue where you have to determine whether the tumor is actually borderline or invasive. We also suggest that EZH2 overexpression can be used as a prognostic marker for ovarian tumors. The strength of our study is that we're able to confirm findings from the published data and that we're able to extend the application of EZH2 in terms of helping the pathologist to differentiate between borderline and invasive tumor. However, there is a bit of difficulty in terms of interpreting the EZH2 expression. We found that in a single tumor section, there is a large variability in the expression of EZH2. It may depend on the preservation of the tumors or in the antigen retrieval stage of immunohistochemical staining. But that is what we notice overall, especially for mucinous tumors. But for the sake of our study, we aim to score the EZH2 expression in the area where there's highest expression. And also, our patient population is somehow very homogeneous. We aim to actually extend our study involving another hospital with a different racial group to see the association of race and other clinical variables in EZH2 expression. We can definitely say that there is a great potential for EZH2 to be utilized as an additional tool for pathologists to differentiate between borderline and invasive ovarian tumors, and that further investigation should be performed in order to validate the application of EZH2 in routine ovarian tumor clinical pathologic analysis, especially now that there are clinical trials for EZH2 targeted treatment for late stage ovarian cancer. So this may have actually treatment implications in the future. So these are my references.
Great. Thank you, Dr. Mendoza. Yeah, you and I corresponded about your presentation ahead of time, so I think some of the feedback that I've given you, you've already incorporated, but one of the interesting things about your population and also Dr. Monsrud was that you had actually, you know, a lot of non-white people, a lot of non-white patients in your population, which is interesting, and it's not entirely common to study these populations, so I think it's really vital. But like you said, to see if these findings match other populations, you're going to maybe look at this in some other patients. And then that difference in the association with invasion, I think, is an interesting thing to investigate in cases that do give pathologists lots of problems, like you and I talked about, like low versus high grade serous carcinoma. These are distinctions that sometimes pathologists are being asked to make now on smaller tissue samples than we had before with the use of neoadjuvant chemotherapy. So it would be interesting to see this marker in a bigger population, in a bigger case series, like you said, and then also maybe see how it corresponds to something like P53, which is also sometimes very diagnostically helpful, at least in the serous setting. Oh my goodness.
Definitely.
Yeah,
definitely. Yeah, that's actually the future plan of our project before we publish.
Yeah.
We already have the data for the P16, P53, and all that correlation.
Okay, well, you don't have to give it away. You don't have to give away all your trade secrets. So let's see. Dr. Gupta, if you'd like to unmute and turn on your camera, you're welcome to join this discussion as well. Thank you for being here. And then there's a long question. What was the rationale to examine this marker in the tumors that you looked at? How did you pick the tumors you picked?
Yeah, that's true. Actually, the primary, our original goal for this project is to just help differentiate borderline tumors versus an invasive tumor. So that's why we only included the low-grade serous tumors and the mucinous tumors, because high-grade doesn't really have a borderline pre-malignant lesion. So yes, definitely, this is one of the direction that we're heading to. We're adding more of the histologic subtypes. I mean, we have a lot of high-grade serous carcinoma in our patient population as well. And yes, there is actually a study now that is connecting ISGyP with BRCA1 and BRCA2 regulation. So that is also an interesting to
yeah, that was a long question. I just picked out the beginning of it, but like you said, there's also associations with other markers, and it sounds like you're going to expand. And the question is about endometrial and clear cell too, because obviously, I mean, it's like once you get going on ovarian cancer, you can really go. You know, there's so many different options, but it seems like you were trying to limit for that reason. And then someone did ask, there were no seromucinous cases in your series, were there? Seromucinous?
There was one.
One, so, okay.
We sort of just divided it into serious and then non-serious for the sake of the analysis.
Yeah, it can get muddy. Yeah. Dr. Gupta, did you want to contribute anything to those questions as well?
I said, you know, we also actually did another study on the cytology, peritoneal cytology, and used EZH2 because that's sometimes people struggle to if they're malignant cells or not. Actually, it turned out to be very useful. So I think most of the use of EZH2 is benign versus malignant short of a distribution, because the amount of staining actually changes from benign to malignant, and then borderline obviously is a little bit tricky. Sure.
Yeah, and borderlines tend to be very tricky on cytology as well, right? Especially on those 1A cases where you might be sort of changing what's happening with the patient. Okay, and then I think I went over all my questions for you, Dr. Mendoza. Now, if you can stop sharing your screen and all the participants can turn on our cameras and our microphones, and we can have our discussion at the end. So thank you all again so much for joining us. I wanted to, in February, we had a follow-up meeting from the USCAP meeting the year before with folks who had published their studies. So this year, or this month, I wanted to talk to people who had presented at the meeting, the annual meeting this year. And the first question I have, and we'll start with the trainees, is what was your experience presenting at the USCAP meeting in a virtual, I mean, pandemic, this is all new to everyone, you know? So we'll start with Dr. Monsrud. What was it like to present at the meeting virtually?
Yeah, sure. So, I mean, you know, got to be honest about it. And I actually had the opportunity to go to the USCAP last year. So just comparing the two, I mean, it goes without saying, it definitely was not a great, you know, overall experience compared to being in person. I mean, you just lose people swinging by and talking about your project. And I mean, I had, I think, one person come by and ask a question in the chat. So it was just very limited.
Yeah, that's true. And what about you, Dr. Aoun? What was it like for you?
I echo a lot of that. It felt like as much as interactive as they were trying to make it, it's hard when you have like 15 other posters being presented at the same time. I had 2 people come and ask questions, and we had actually a really good conversation, which would have been nicer if it was in person. I didn't personally go to USCAP last year, but I'd imagine it would have been a much greater experience in person, but we have to make do with what we have. And I thought the organization and like the poster hall and actually having them as PowerPoints instead of like poster like format that I have to like zoom in on every single part to read what it is, and sometimes get like disengaged. If I know what I'm looking at is like a 12-slide PowerPoint with like, this is what I need to know, it's easier to like keep my attention span and focus, and like me to ask questions based on that.
Yeah, that's true. It is the way we're learning in every other format that we learn from, right? Is the, you know, kind of piecemeal, not like this tableau where you sort of have to engage virtually. So what about you, Dr. Mendoza? Did you want to comment on what it was like for you?
Yeah, I would like to echo their concern. Like there's much less interaction this time because probably there's like 100 of, you know, online posters that you can go to. I was in USCAP for the past 2 other years, and it was such a beautiful experience interacting with people. I met a lot of program directors, and they really have very good feedback on your poster. And this time it's just, you know, 1 or 2 questions. So I kind of miss that physical interaction.
Yeah, I will say that as someone who hasn't been able to go to USCAP lately, just for like work reasons and family reasons, the one thing I do appreciate is that when I want to go look back at a poster now, I can have the recorded voice of the person whose study that it was. So I'm hoping going forward, we actually have some combination of the two, because I always found going back and just looking at the poster or looking at like an evening presentation, it was so much harder to tell what went on, and just hearing your voices talk about your projects. It was, so I agree. And I will say, as someone who was working during the poster sessions, my institution actually blocked the posters, so I couldn't get to them, but I wanted to be there. But I think we all wish we could have supported you more. It was a busy time. Did any of the mentors want to comment about that question as well? No? Okay, that's fine.
Well, I think,
go ahead.
I agree with, you know, I think the interactive is great, but going forward, they can take the good things from this, this experience. I do really like the going back and listening to the recordings, and it makes it easier. You know, we are all better audio learners than just, you know, so when you have both the audio and the visual. So I think going forward, even when it becomes alive, they can, you know, have these recordings for, you know, available for some months down the line.
Yeah, and I liked having the PowerPoint as well, because like you said, I don't know if they'll end up doing both or a hybrid, but it was certainly nice for those of us who have to play catch up sometimes. So, and then I did want to ask the question, because I think it's so important to those who are interested in a career in academics, maybe, or private practice, or just GYN pathology. I wanted the mentor-mentee matches that we have here to just talk about how the project idea came about and how the trainee became involved. So we can start with Dr. Monsrud and Dr. Krishnamurthy, if you two want to talk about that first.
Sure, yeah. So, I mean, I got involved, like I joined Dr. Krishnamurthy and Dr. Mosenjak at Grady from the get-go as a medical student. So that's how I got involved with research with them, and they both share interest in GYN as well. And so we particularly got on the topic of PDL1, starting with anal, anogenital region. And it's just because it's so minimally studied. There's not many studies on that. And then I think it just made a perfect segue for the cervical cancer. as well as I think that we're in a particularly interesting patient population at Grady, both being a public hospital, so lower to middle income class, and as well as predominantly Black underserved patient population. So I think that gives us, you know, an equitable population to study, especially for cervical cancer.
Yeah, that's true.
And I mean, it's been a pleasure working with Ashley. So she, you know, follows everything, you know, great on taking feedback, all that. So it's been a really good experience.
Yeah,
and we have lots more things planned.
Yeah, it sounds like you all are very productive. You're working well together, so that's very important. And what about Dr. Aoun and Dr. Scala? Would you like to take the next round?
Yeah, so when I started residency, I was, you know, interested in getting on board of a research project as soon as, you know, you settle in and you like get used to your rotations. And I was particularly looking for a GYN project, and Dr. Scala emailed me about this topic. And I really liked it initially because it wasn't very molecular heavy, which is one of my weaknesses. I mean, I can read about it all the time. Yeah, I mean, I could have read about something that was molecular heavy, but the project caught my attention because I like looking at H&E morphology and, you know, and making conclusions from there, and also supplementing it with IHC. So I really like the project. And I find that one of the most overwhelming parts about starting a research project is finding your articles and your like online resources. So Dr. Scala did a very nice thing of attaching a lot of articles for me to go through. And from those articles on PubMed, I got to also hop on other articles, and I kind of found my a good literature group to kind of go in and kind of sample from and cite. So that was really nice, especially because as a first year, you know, and who doesn't have a lot of research experience, it's very intimidating to start a research project. So she made it very easy and kind of seamless for me. And ever since then, her office is like 5 minutes down from where we are, from our resident space. Every time she has a case that comes up on service or comes up on with every other attending, she's like, I got a recut for you and I got stains already, or I got a cool case to show you. So I'm always like running to her office and grabbing cases and putting them in my Excel sheet. So it's kind of a very kind of direct communication. And she's always available if I need any questions, or if I'm like, well, I don't know what P10 is, because P10 is one of our newer stains. And, you know, she directed me towards articles and things like that. So she's a great mentor. It's a very easy kind of communication and relationship. So
that's great. Dr. Scala, would you like to comment?
Yeah, I'd say Batoul does a great job of asking questions when she needs help, but is also incredibly impressively self-sufficient too. So it's like I help where I can, but also I think a lot of the success of everything she's done comes from her and not so much from the guidance.
Yeah.
But that's kind of one of the fun things about mentoring, I guess, is helping people to thrive themselves.
Mm-hmm. Yeah, I think that just even that specific example that Dr. Aoun gave of you sending her a bunch of articles, I find just sort of like demystifying, or just getting a trainee started and sort of making the process approachable. It sounds like that's really happening. And like I said, I agree, this is not a molecular heavy project. It's so practical though, you know, and especially since you all are following up on these patients and kind of saying, well, this is what it looked like when you only had a millimeter, and this is what the hysterectomy looks like. So you can kind of get an idea when you have the biopsy and you don't have the follow-up, like what are my possibilities? What can I tell the clinician to look for or think about? That's great. Okay, and Dr. Mendoza and Dr. Gupta, would you like to finish us up here?
Yeah, so I would just like to mention that Dr. Gupta is the #1 source of projects for all the residents in our program. She is the #1 supporter for everyone, and I was just so lucky to have been part of her. I still remember her walking when I was PGY1. She walked into the residence room, had this journal in hand, and said, who wants to work on a project for cervical cancer? And I just raised my hand. It's like a race, you know, and it's all started from there. All my USCAP abstracts and a lot of my papers came from the guidance of Dr. Gupta. She will provide you with anything, including financial financial support. Yeah, which is very important. So
yeah.
Well, thank you, Rachel. I must say she's very humble, and she actually is very smart. She is self-directed. She comes up with projects. We have a good collaboration with GYN department, and we have large data sheets that we have made with ovarian cancers, and we have a continuing sort of update of. So I think it makes it easy for us to involve a resident, and let's say we want to try immunostain. We have survival studies, data, etc. together. I think that's.
Yeah, that's really, highlighting the clinical component and then sort of having that underlying research structure. You don't have to go back and reinvent the wheel every time. That's really great. That can probably also make it a lot more approachable for residents. So, well, I thank you all for being there. In the interest of time, we're 5 minutes past the hour, so I think I'm going to finish up. But I want to thank all of you for being here, and we really look forward to seeing your projects in wherever they end up landing. We want to read all about it. So, thank you so much.
Thank you.
Thank you
so much.
Thank you.
Bye.